Good afternoon, everyone.
Good afternoon, sir.
Sir,
Good afternoon, sir.
Huh? I hope everybody is feeling good today after a one-day break, which I'm told was Ash Wednesday, right? I hope you have not given up studying for length. Okay? Has anyone given up studying for length?
we want to, sir, but we cannot cross it.
Okay, okay. I like the spirit. All right. I
The
did
lectures are still not uploaded, sir,
my
or the
what?
course outline.
Go again. Could you repeat what you said? Hello?
Sir, Makisha was saying that the course notes are not yet up, neither is the course outline.
All right, I speak to Dr. Sapna about the outline. I did email Miss Prince the lectures today that we have covered or will cover, including the two for today. I know she usually prints them and distribute them. I don't know if everyone has access to the course site. Everyone has access?
Yes, sir, we have access. It's
All
not
right.
there yet, unfortunately.
All right, I'm gonna post them. All right, I'm gonna post them. Sorry about that. All right, so as I promised the last time, I want you to have a good grasp of the concept of the healthy worker effect. And I've been mentioning the fact that workers are very special people. They are carefully selected from the population. Very often they have to undergo medical tests of one kind or another. So the end result is that the healthiest segment of the population is found among working people. So when we talk about the healthy worker effect, we're talking about a comparison of the mortality rate of an occupational group with the rate of the general population. And what we find is that typically the overall mortality rate of an occupational group is lower than the rate in the general population. And this is so because of three main factors. One is confounding, the other is information bias, and the third is selection bias. So when we talk about the healthy worker effect, we're not talking about morbidity. We're talking about mortality rate. And so if you find that the mortality rate in, in the general population is, sorry, if you find that the mortality rate in the working population or the occupational group is much higher than it is in the general population, it simply points to the fact that there is something at work which is causing this increased mortality, since we expect the overall mortality rate in workers to be less than the general population. So, according to last 1995, the HWE, or healthy worker effect, is a phenomenon observed initially in studies of occupational diseases. Workers usually exhibit lower overall death rates than the general population because the severely ill and the chronically disabled are ordinarily excluded from employment. And so we can speak to what we refer to as the strength of the healthy worker effect. and we will illustrate this more vividly as we go along. So the strength of a healthy work effect depends on a number of factors. Time since hire and time since start and follow up in the case of a epidemiological study, the cause of death, the age of the worker, the race of the worker, and the gender of the worker. So let's look at each separately. So in the case of a disease, the healthy worker effect is strong for heart disease and weak for cancer. Now, what do we mean by this? When we say the healthy worker effect is strong for heart disease and is weak for cancer, what we simply mean is that there is a distinct difference in the way heart disease affect workers. So you hardly find a healthy worker dropping dead from heart disease, right? You generally find people in the general population being more affected by heart disease than people in the world of work. So it is strong. And what we mean by strong is that there's a big difference in the mortality rate for heart disease when we look at working people versus the general population. And we say it's weak for cancer because cancer tends to kill people later in life. And so whether you are an older worker or a retired worker or you're in the general population, cancer usually kills people at a higher rate, so let us say 60 plus years. And so when we say it is weak, we mean that the mortality rate from cancer in workers is closer to the mortality rate in the general population. So for the healthy worker effect to be strong for a disease, it means that for that particular disease, much less workers are dying than in the general population. And when we say it is weak, we mean that the number of people dying in the world of work compared to the general population is much closer. All right? Again, for age, we say it's strong for the young and it is weak for the old, which is self-explanatory. In terms of race, studies have found that it is weaker for Caucasians than for people of African origin. And for gender, it's stronger for males than for females. And sometimes, if you look at the disease being considered, all causes versus specific disease, it can be either strong or weak. So is the healthy worker effect a selection bias? The answer to that is yes, because people are carefully selected to enter the world of work, and many people are excluded because they may be considered to be unfit or unhealthy. We have discussed confounding already, and you would have discussed it in your other EPI classes, so you should have a good understanding of what confounding is. But just to cite an example here, where we said that a confounder is a third variable, which is related to the exposure, but is not caused by the exposure. And it also related to the disease and could cause the disease. So if you're going to do a study and there's a confounder which can distort the true association between exposure and disease, then you're not going to be able to interpret very well whether the effect is caused by the confounder or it is caused by the variable of interest. So the example being illustrated here, it says here that coffee drinking can lead to heart disease, and cigarette smoking can also lead to heart disease. So cigarette smoking in this case would be the confounder, because cigarette smoking is associated with coffee drinking. I mean, cigarette smoking is not caused by coffee drinking, but many people who actually drink coffee also smoke. And definitely, we know cigarette smoking can cause heart disease. So we spoke about the standardized mortality ratio already. The ratio of the number of deaths observed in the study group or population to the number that would be expected if the study population had the same specific rates as the standard population, and this case is multiplied by 100. Because usually when you divide observed by expected, you get a very small fraction. And so to make that fraction into a whole number that we can interpret, we multiply that by 100. So in looking at associations using standardized mortality ratio, the point of no association is 100. Whereas in cohort studies or follow-up studies, when we look at relative risk, the measure of association, if there's none, is 1, and the same thing for the odds ratio. But in the case of the SMR, we multiply by 100. So this is an actual study that was done to illustrate, illustrating the healthy worker effect. And they're looking at the cause of death and the years since higher. And it came from this study. SMRs, hourly synthetic rubber industry workers. This study was conducted between 1944 and 1998. So if you look here, there are a number of causes listed. So there's all causes of death. Deaths due to cancer, deaths due to circulatory disease, deaths due to non-malignant respiratory diseases, and lastly, external causes. And then you have the data for all subjects, and then years since higher, those less than 20 years, those 20 to 29, and those 30 plus. So if you look at all causes for all subjects, the SMR is 89. Now, how do we interpret this 89? The way to interpret the 89 is to say that the mortality rate in workers is 11% less than in the general population. For cancer, for all subjects, it is 96. It means that the mortality rate in workers is 4% less than in the general population. For 92, it would be 8% less. For 82, it would be 18% less. And for 72, it would be 28% less. In terms of years since higher, less than 20, for all causes, the SMR is 64, which means that the mortality rate in workers is 36% less than in the general population. If you look at cancer, for persons hired for 20 to 29 years, it is 100. How do you interpret that 100? What it simply means that the mortality rate in workers is the same as the mortality rate in the general population. And going over across to 30 plus, where the SMR is 102, what this means is that the mortality rate in workers is now 2% more than in the general population. So an example of a strong healthy worker effect, if you look at 89, all right, if you look at 72 for external causes for all subjects, this is 28% less in workers. So that healthy worker effect would be very strong compared to say 96, which is 4% less. Are you following? Am I making sense? Hello?
We're here, sir. Perhaps you could go it over one more time. Can you?
All right. I'm saying that, okay, you have the different causes of death, and you have for all subjects and the period of time for which they are employed. Less than 20 years, 20 to 29, 30 plus, right? And then you have for each the corresponding SMR. Remember, the way you get to the SMR is that you divide the observed deaths among workers to what was expected. Okay? And whatever you get, you then multiply it by 100. So you end up with a nice whole number that you can work with. So let me just repeat. Let me ask somebody to interpret something from it. If we look at external causes, right? Under the 20 to 29 years since higher group, the SMR there is 71. How do you interpret that 71? You would simply subtract 71 from 100 and you would get 29, meaning that the mortality rate in workers is 29% less than in the general population. Would that healthy worker effect be strong or weak? Yes, it would be strong. A difference of 29% between workers and the general population is substantial compared to, say, all causes 30-year plus, where the SMR is 99, which means that the mortality rate in workers is just 1% less than in the general population, right? So again, to repeat, the healthy worker effect is strong when the difference in the mortality rates between workers and the general population is significant, right? And it is weak when there's hardly any difference between the two rates. Is that clear?
Yes, sir.
All right, so let us look at this consumer retrospective follow-up study. Ford Company and talc miners and millers, right? Again, you look at cause of death, all causes, all cancers, ischemic heart disease, non-malignant lung disease. For Ford, SMR 92, 100, 93, 80. For talc, SMR, all causes 131, all cancers 151, ischemic heart disease 110, and for non-malignant lung disease 221. So at a glance, you should be able to detect that the healthy worker effect at talc is significantly greater than the healthy worker effect at Ford. So if you look at all causes at Ford, it was 8% less in workers. At talc, the SMR was 31% greater in workers, right? So if you had to choose between these two places to work, which would you choose and why? Which workplace is a safer place to work? Hello? Which place is a safer place to work based on the SMRs? No answer?
Ford, sir.
Ford is safer. Exactly.
Mhm.
Exactly. Because if you look at all causes of death, at Ford, the difference between the healthy worker effect, the healthy worker effect is 8% less among workers than the general population. Whereas at talc, it is 31% greater in the workers. And any place where you find workers are dying at a much higher rate than in the general population, it means that there is something at work that is killing the workers, right? So clearly, the situation is worse at talc because in every case for all the causes of death, right, the mortality rate in workers is much higher than in the general population. It is 31%, 51%, 10%, and 21% respectively. All right. So you can get information on standardized mortality rate, which, as I said before, is a comparison of the mortality rate in an occupational group to that in the general population. And typically, the death rate or the mortality rate in workers is less than in the general population. So if you have a workplace where workers are dying much more from a particular cause than in the general population, then you don't have to look far. There is something in that workplace which is causing the excess mortality among the workers. So you need to understand this. You should be able to look at a published paper on SMRs and draw your own conclusions. Right? So in an exam, I could give you back the same table in an exam and ask you to interpret something. Right? What you need to get is the principle, not to memorize what is in the table. Because these numbers could change. But if you get the principle that typically the mortality rate among an occupational group is less than in the general population, right? When you see the mortality rate in the occupational group is now greater than in the general population, it simply means that that workplace is dangerous. All right, and this is something you must understand as well. We know, for example, that for infectious diseases, they have incubation period, which may be hours to days or days to week. And in the case of a disease like listeria, it could be 2 or 3 months. All right. So when we talk about occupational and environmental diseases, especially those due to chemicals, we don't talk about incubation period. We talk about induction time. We talk about latency period. And we talk about empirical induction time or period. All right. So the empirical induction time or period is time since first hired, from the first day on the job going forward. All right? So what this diagram is illustrating, one, what we mean by induction time, and two, what we mean by latency period, and three, what we mean by empirical induction period or time. So if you look right, so if you look here, there is an exposure. So exposure starts at A and it continues going forward. So the exposure begins at A, and at B, and we're talking about a typical disease, the etiology will be completed at B, right? And then at C, a case of disease could be diagnosed, or somebody could have died and the postmortem revealed that, yes, this is what killed the person, right? So A is where exposure begins. B is where disease etiology complete. And for different people, disease etiology will be complete at different time. But we're just using this illustration for convenience. And then C is where a case is diagnosed or somebody dies from the disease. So from A to B is called the induction time, right? And from B to C is called the latency period, all right? And from A through B to C is called the empirical induction time or period, all right? So let me ask you this then. If a particular disease could be diagnosed earlier, if technology advanced to the stage where we could diagnose a disease earlier, what, if anything, would happen to the induction time, the latency period, and the empirical induction period? What, if anything, would happen? So let's start with the induction time. What would happen to the induction time if we could diagnose a disease earlier?
The time would be shortened.
Right, so the induction time would be shorter, right? So the induction disease etiology B probably would be moved closer to A. So it could be here, for example. All right. What would happen to the latency period?
We'll have a longer latency period.
You think so?
Yeah, because if you can get the diagnosis from early, it means that progressing to the case or the death would take longer if you can get treatment in.
No, but the case would you correspondingly if you're going to diagnose the thing earlier, you're going to pick a case earlier as well. So nothing would happen to the latency period.
If you cure it, nothing will happen.
Right, and what would happen is that the induction time would be shorter. The latency period will remain the same, and the empirical induction period would also be shorter. Because everything is moving now towards A if the disease is diagnosed earlier. You get the point?
Not really, sir.
All right. Let me go through it again. I said you could if no, I did say something I should not have said. Let me go it over again, right? Exposure begins at A. The disease etiology is completed at B, right? And you can now diagnose a case earlier. So really, what will happen in reality is that the induction time would be the same, but the latency period will be shorter because you could diagnose it earlier. Is that
Wait,
clear?
wait, hold on, sir. You just said the induction time would be longer, would be
No,
shorter.
I'm changing that. I'm changing that.
Oh,
I'm
okay.
changing that. Right. I was concentrating on B, but we should be concentrating on C because this is at C that you diagnose the disease, not at B. Do you understand? The disease develops, and for some people, it may be diagnosed here, it may be diagnosed here, or it may be diagnosed here. You get the point? But if we can now diagnose it earlier, the C would then move closer to B. I did say B would move closer to A. That is not so. The C would move closer to B. So in effect, the induction time would be the same. It would take the same amount of time for the disease to develop, but you can detect it earlier. So C would then move closer to B. So in effect, the induction time would remain the same. The latency period would be shorter. And because the latency period would be shorter, the empirical induction period will also be shorter. We all see that now? Do we all see
Can
that? Huh?
so we're saying that
Go ahead.
the period so the time from exposure to actually cause the disease is the induction time.
No, man. Mm-mm. All right. This arrow needs to be realigned. So A to B is the induction time, and
Oh,
B to
okay.
C is the latency period.
Oh, so I just put those letters under the relevant areas there to more align it then.
Right.
So
So
it
the
would mean
arrow
that C would move backwards to B if we are diagnosing it earlier.
earlier,
So
right.
B to C would be shorter,
But A to B would be the same.
but A to B would be the same. Okay, all right,
Right.
no
So,
problem.
so, so just to summarize, then the induction time, which is A to B, would remain the same. The latency period, which is from B to C, would be shorter because you are now diagnosing the disease earlier. So C would move a little to the left. Good? And
Yes, sir.
because the latency period will be shorter, the empirical induction period would also be shorter. But induction time would be the same.
Okay, sir. Got it.
All right, good. So you need to try and grasp the concept of the healthy worker effect. And these terminologies with regards to environmental and occupational diseases, which are caused by chemicals and not by microorganisms, which have definitive incubation periods. And generally speaking, the induction time and latency period for these diseases span years, if not decades. It's not like for infectious diseases where within 3 days or sometimes less than 24 hours, people start to manifest with signs and symptoms, right? For environmental and a lot of the occupational diseases, the induction times and latency period spans many years, if not a few decades. All right? So we can leave this now and we can proceed to the first of the two lectures for today. All right, so let me share again. All right, so what we want to talk about today are, no, this is not the one. Wrong one. Stop share. Binder. Right. Where is this lecture? Yeah. Okay, just try and find this lecture. Lecture 3. This lecture won't appear. It's just inspection. Ah, okay. Here we are. Eureka, Eureka. Okay, so what I want to do for the rest of the afternoon is to look at the different systems of the body and to discuss some of the disorders or diseases that could affect them. And we want to start by looking at occupational lung diseases. And I want to say at the outset that the prevalence of occupational lung diseases rank third in all work-related diseases. The number one condition affecting workers is skin conditions of one type or another. Number two is trauma from various sources. And number three is lung diseases. So while the prevalence of lung disease is ranked at number 3, if we look at mortality associated with these three conditions, we'll find that lung diseases account for much more deaths than skin conditions or trauma. But just looking at prevalence, which would be the number of new and old cases of disease, lung diseases rank at number 3, trauma at number 2, and skin conditions at number 1. I did say at the outset that I'm aware that many students in the group would be very, very familiar with the respiratory system and how it works. For those who may not be so familiar, you need to read upon these systems so that when we talk about certain things, you can actually visualize what we are talking about. So illustrated here is the respiratory system. I won't go into all the anatomical structures. I just want to refer to the alveoli, which is where gaseous exchange takes place. And so when we breathe in air, we are not only breathing in oxygen, which we need, but we may also be breathing in other gases like carbon monoxide and chlorine and ozone, nitrogen dioxide, sulfur trioxide, all of those gases, which can have deleterious effect not only to the lung tissue, but the general health of the person concerned. And there are some associated terminologies. Again, I'm going to leave you to read and understand what these are: ventilation, inspiration, expiration, and forced expiration. So sometimes we take a deep breath, and sometimes we breathe out forcefully. That would be forced expiration. And there are certain things we refer to as volumes. So we talk about tidal volume, the expirator reserve volume, the inspirator reserve volume, and the residual volume. Now, no matter how hard we breathe out, we cannot empty the lungs. There's always some residual left in the lungs, and this is what we call the residual volume. There are lung volumes, which I want you to pay some attention to. So there's what we call the total lung capacity, and that's the volume of air contained in the lungs at the end of a maximal inspiration. So when you breathe in as hard as you can, you're trying to meet the total lung capacity. And then it is called a capacity because it is the sum of the four basic lung volumes, which is the residual volume, the total, the tidal volume, and the inspiration and expiration reserve volume. And then we have the vital capacity, which is the maximum amount of air that can be exhaled after we take the deepest breath possible, right? And then VC is equal to IRV plus TV plus ARV, and this is the same as TLC minus RV. So you can, the equation is there, it's not complicated, you can just reason it out by looking over the different volumes. And again, this diagram illustrates what I've been talking about, all right? So total lung capacity, residual volume, you breathe out as hard as you can. There's some air left in the lungs, all right? And all of that. Now, in terms of measures of ventilatory performance, so people are suspected to have a lung problem. There are ways in which we can do certain measures. And when we do certain measures, we can compare those measurements to standards that are set, and they can reveal to us if something is going on in the lungs. All right? So I want you to pay particular attention to this page where we talk about forced vital capacity, which is the total volume of air exhaled during a forced expiratory maneuver, which is the act of exhaling as hard and as fast as possible after taking as much air as you can take in. So that's forced vital capacity, or FVC. And then there's the forced expiratory volume in the first second, or what we call the FEV1. And it's the amount of air a person breathes out during the first second of a forced expiratory maneuver. So when we breathe out, right, the air that is expelled during the first second is called the forced expiratory volume in the first second, or the FEV1. Now, under normal circumstances, when we breathe out forcefully, in the first second, we expel 80% of the air in the lungs. All right? And we express that as FEV1 over FVC. All right? So 80% is the same as 0.8. So the way they do it, and the doctors in the group can explain to you, there is an approach to evaluating lung performance or ventilator performance, and people are subject to spirometry, which measures the amount and rate of air a person breathes in order to diagnose illness or to determine the progress in treatment. And the way it is done is that you blow into an apparatus which is connected to a computer system, and usually there is somebody there who is conducting this spirometric measurement. Very often people have to be told how to breathe in and out as hard as they can. And so sometimes they may take 1, 2, or even 3 readings for 3 attempts and work out the average. What I want you to be aware of is that if someone has a serious lung problem, which would mean that if you breathe out hard, you're going to feel pain, then that person may not breathe out as hard as he or she should, and so you're going to get a false reading. You could get a normal reading when in fact that person could be very sick. And so that is why it is important to tell people about the importance of breathing in and then breathing out as hard as you can, so that if something is wrong with the lungs or your ability to do that, then it could be detected. And if something is wrong, then further investigations could be done. People could be subject to a X-ray or a CT scan or some other thing to arrive at a diagnosis of a lung condition. But remember that in diagnosing occupational diseases, the best thing available to the investigator is to take a proper and complete history, an occupational history. You can't just have somebody in your office and you send them to do a test. What test are you going to send them to do? Very often, what will guide you as to what tests you should order, those answers will be provided by the occupational history. So that is very important. And very often, busy physicians don't have the time to take that detailed history. And so important occupational problems could be missed. So for spirometric measurements, abnormal measurements may reflect evidence of lung disease. The predicted values to which you are going to compare your measurements to, they're influenced by age, height, gender, and race. And you also should be aware that lung volumes for females are about 20% less than that of men the same age and height. All right? So you need to be aware of that. So this is just a table looking at the different staging of chronic obstructive pulmonary disease by spirometry. All right? So somebody who has a mild problem, you're going to have the FEV1, which you said is the forced expiratory volume in the first second, is going to be equal to roughly 80% or greater of that is predicted. So when you divide FEV1 by FVC, you're going to get less than 0.7. And it's going to be the same for all, just that for moderate, it's going to be equal to 50, or less to 80% of what is predicted. For severe problem, FEV1 is going to be less than or equal to 30% to 50% of what is predicted. And in a very severe case, then FEV1 is going to be less than 30% of that which is predicted. So this is how you would compare your spirometric measurements to the standards that are set, and to determine if the COPD stage of the person is mild or moderate or severe or very severe. We spoke a little about restrictive lung diseases, and I did tell you that people who suffer from restrictive lung diseases, they find it very hard to breathe in, to take air into the lungs because of the scarring or the fibrosis within the lung tissue that makes the lung tissue less elastic. And if the lung tissues are less elastic, then you're not going to be able to breathe as normally as you can and taking in as much air as you would want to. All right? So both FEV1 and FVC decrease, and thus the ratio remains at 80% or 0.8. And I did mention to you the classic pneumoconiosis, the silicosis, the asbestosis, and the coal workers pneumoconiosis. And we also have hypersensitivity pneumonitis. So we're going to talk about them in a little while. For the obstructive lung diseases, they make it difficult to get air out of the lungs. Asthma, byssinosis, the classic COPD is emphysema and chronic bronchitis. So just remember that for restrictive lung diseases, difficult to get air into the lungs. For obstructive, difficult to get air out of the lungs because there's something in the tubes in the lungs that is blocking the movement. All right. We did also mention occupational asthma, which I did tell you would be caused by chemicals at work that either irritate the lungs or the workers become sensitized to them. So when they're exposed, there's an allergic reaction. So whether asthma is occupational or not, is characterized by these three things. There's some airway obstruction, there is some airway inflammation, and there's increased airway sensitivity, right? And occupational asthma is the most common work-related respiratory disorder. Don't forget that. It is the most common work-related respiratory disorders because there are so many chemicals workers encounter in the occupational environment, which will either irritate the lungs or cause sensitivity to develop. And this is just illustrating why asthma makes it hard to breathe. So if you look on the left, you will see the inflamed bronchial tube of an asthmatic. And on the right, you see a normal bronchial tube. So on the left, there's obvious obstruction there within the bronchial tube. So there are two types of occupational asthma, as I alluded to. There is sensitizer-induced asthma. So somebody becomes sensitized to a chemical, maybe a gas, a fume, or something, and you become sensitized, and this may take up to a year or more, right? But once you encounter that substance again, it's going to trigger an asthma attack. So a low dose can provoke asthma, and people are sensitive to specific agents. And some workers may be sensitive to an agent while others are not. All right, good. Then you have irritant-induced asthma. This happens without a latent period. So once you come in contact with this irritant, you're affected. And usually people who are exposed to people who are exposed to a high dose of irritating chemical could precipitate an asthma attack. And then, who's making those sounds? And then if you want to find out or establish a relationship between asthma and work, you need to ask these questions. Do workers have symptoms only at work? Do the symptoms improve on weekends or vacation? Do symptoms occur regularly after the work shift? Do symptoms progressively increase with time? And do symptoms improve after a change in work? So sometimes what management should do is if a worker is showing obvious sign of occupational asthma, one of the things they can do is remove him or her from that work environment, or if they know what the chemical is and can replace or substitute that chemical, you will find that the symptoms could improve in the worker. So occupational asthma is a big problem among workers. Emphysema, again, this disease is chronic, as you know. The main cause is smoking. And the last time I told you about this rare genetic disorder, alpha-1 antitrypsin deficiency. Doesn't affect a lot of people because it's a rare genetic disorder, but people are also subject to air pollution, and that could lead to emphysema in the long run. Again, you can see what is happening here. Excess mucus in the bronchiole, enlarged alveoli, fewer capillaries. So if you compare the normal, lung tissue with with emphysema, you can see what is happening up here. This is showing emphysema, and this is normal bronchiole and alveoli. Symptoms: shortness of breath. Some people have a barrel-shaped chest, there's wheezing, there's fatigue, and there can be weight loss without trying. For chronic bronchitis, this is a classical definition for chronic bronchitis. It is characterized by excessive bronchial mucus and a productive cough that produces sputum for 3 months or more in at least 2 consecutive years without any other disease that could account for this symptom. And symptoms: cough that produces mucus, shortness of breath, frequent respiratory infections, fatigue, headaches, may have ankle, foot, and leg swelling. Again, you can see normal airway, or the air flows nicely, and there's airway obstruction here. So you have restricted airflow, a lot of mucus, and narrowed airway. For the pneumoconiosis, yeah, sorry about that. For the pneumoconiosis, we did say it results from dust being deposited in the lungs, and this causes of an irritation, and the scarring takes place, and all of that. So let's look at them quickly. For silicosis, there are three different forms: acute, And that can result in 2 years, the most serious form. Then you have subacute, or another term they use for subacute is accelerated, where you have progressive massive fibrosis. That's what PMF stands for. And it develops in 2 to 5 years after exposure. And then you have chronic simple silicosis due to low concentration of dust, and this develops usually after 10 years, and people end up with silicotic nodules. If you do an X-ray, you'll see the silicotic nodules right there in the lungs. And this diagram summarizes what I think I need to know about silicosis, so pay attention to it. For asbestosis, it is caused by exposure to asbestos. And asbestos is a generic term for a group of 6 naturally occurring minerals, which we use in a lot of commercial products. There are two main groups of asbestos. We have the serpentine asbestos and we have amphibole asbestos. The serpentine group consists of just one type of fiber, which is chrysotile. Chrysotile is also called white asbestos. It is the most commonly found asbestos that is used in a lot of commercial products. And then for the amphibole group, there are 5 fibers: amosite, crocidolite, tremolite, actinolite, and anthophyllite. Now, all of these fibers are dangerous, just that some are more common than others. So chrysotile is called white asbestos, amosite is called brown asbestos, and crocidolite is called blue asbestos. So the 3 most common types we encounter are chrysotile is by far the most common, then amosite and crocidolite, but we also have the other 3, and all are dangerous.
Sorry, sir. I hear you mentioning a name. I didn't see it on that side. You said chrysotile?
Yes, it was on the previous slide. Chrysotile.
Oh, okay. Okay. All right.
Right. So the
Thanks.
point I was making here is that serpentine group has just one asbestos fiber type, which is chrysotile.
Right. I realize.
And then you have the other 5, which is amphibole asbestos, amosite, crocidolite, etc. The major route of exposure to asbestos fibers is through inhalation. We can also ingest asbestos fibers, and dermal absorption would be confined to people who work like in the asbestos mines and work with a lot of asbestos. And when we say absorption, it doesn't really go through the skin, right? But what happens is that it affects the skin and people end up with nodules or corn, as the case may be. The other thing to note is that in terms of ingestion, most of the fibers that we inhale, we end up ingesting them because of the mucociliary thing that is happening up there. So we ingest a lot of stuff involuntarily. But in terms of health effects, the main problem is inhalation. And the fibers vary with respect to a number of things, size and chemical composition. And these differences will affect how far they are deposited in the lungs, how they move, how they are cleared from the body, and also their carcinogenic potency. But all are dangerous. There is none that is not dangerous. So this is a highly magnified photograph of asbestos fibers lodged in the lungs. You can see these black things here, right? All right, so in terms of major health effects, don't forget now, asbestos is an established class 1 carcinogen. So said the International Agency for Research on Cancer, the Environmental Protection Agency in the US, OSHA in the US, NIOSH in the US and ACGIH in the right. So there is consensus globally that asbestos is a class 1 carcinogen, and so it causes mesothelioma of the pleura and the peritoneum, as well as lung cancer, and it causes fibrotic diseases like asbestosis, which is not a cancer, and pleural plaque, which is also not a cancer, right? So asbestosis and pleural plaque would be non-malignant respiratory conditions, whereas mesothelioma and lung cancer would be carcinogenic, would be malignant conditions. So there is pleural mesothelioma. It's a rare form of cancer, but it's pretty dangerous. Pleural mesothelioma is much more common than peritoneal mesothelioma, and those are signs and symptoms. Induction period may be 30 years or more, right? Remember that induction period now would be the time from first exposure until the disease is fully developed. After the disease is fully developed, then it may be diagnosed at various stages. So after induction, you're going to have the latency period where between the time the disease is developed until it is diagnosed, detected, or somebody dies from it. And peritoneal mesothelioma is less common than the pleural form, but it tends to be more invasive. It results in shorter life expectancy. And you can see some symptoms there: belly pain, nausea, vomiting, weight loss. Once you are diagnosed with this disease, the prognosis is very, very poor. And so patients seldom live longer than 12 to 18 months after diagnosis of mesothelioma. Asbestosis, I repeat, is a serious, progressive, long-term fibrotic disease. It's not a cancer. It's a restrictive lung disease, and it's caused by the fibers that irritate and inflame lung tissue, leading to scarring. Induction period 10 to 20 years, and you can see some of the signs and symptoms listed there. Again, you can see asbestos fibers lodged in the lungs. But lung cancer, you all know, well, it's a malignant tumor, so it invades and obstructs the lungs' passages. We know, and you should never forget that cigarette smoking and exposure to asbestos fibers is synergistic in causing lung cancer. And there are a lot of symptoms there: cough, wheezing, unexplained weight loss, coughing up blood, labored breathing, persistent chest pain, hoarseness. A lot of these symptoms are not peculiar or what they say pathognomonic to lung cancer. It can be caused, coughing up blood can be caused by somebody with tuberculosis, right? So, but lung cancer, in some cases, lung cancer, you do cough up blood because the lung tissue would have been seriously compromised. In terms of the factors that affect the development of disease from asbestos, the type of fiber is important. So the literature tells us that asbestosis is associated with fibers greater than 2 microns, mesothelioma greater than 5 microns, lung cancer greater than 10 microns. And remember what a fiber is. A fiber is a solid particle with an aspect ratio of at least 3 to 1, meaning it is at least 3 times as long as it is wide. The exposure concentration is important. How long you have been exposed is also important. The chemical makeup of the fibers. If you smoke, individual susceptibility, if you have pre-existing lung disease, and the OSHA or the OSHA permissible exposure limit for asbestos is 0.1 fiber per cubic centimeter of air. and this standard has been coming down. At one stage, I think it was 1.5 fiber. Currently, it is 0.1 fiber per cubic centimeter of air. For oil exposure, again, I did mention the fact that most of the asbestos that we inhale are transported by the mucociliary action to the pharynx, where they are swallowed. All right. The health effects of ingesting asbestos are somewhat inconclusive. Some people tell that it causes cancer of the gut and all of that, right? But the EPA in the US has established a maximum contaminant level for asbestos in drinking water, and that is 7 million fiber per liter. So think about somebody ingesting 7 million fiber per liter in water, and compare that to somebody inhaling asbestos, and the standard is 0.1 fiber per cubic centimeter of air. So as you can see clearly that inhalation of asbestos fibers presents the greatest danger to any human being. So here in Jamaica, I think we still have in place some asbestos cement pipes used for drinking water. And I'm aware that the National Water Commission was trying to change them out and replace them. But one of the things that they did that was wrong was that they dug up these pipes. Now, if you dig up the pipes, then for disposal, you have to bury them again. So why not leave them where they are and put in new PVC pipes above them or beside them? All right. So sometimes we take actions without thinking it through. All right. So I mentioned the dermal exposure. You end up having warts or corn, and there's no quantitative dose response data available. So we can't say what amount it will take on the skin to cause certain problems. For coal workers, pneumoconiosis, CWP, you get it from inhaling dust in the coal mines. And there are two categories of CWP. You have simple coal workers pneumoconiosis, and you have complicated coal workers pneumoconiosis, or what we call progressive massive fibrosis, or PMF, depending on the extent of the disease. So diagrammatically, you can understand why they call coal workers pneumoconiosis black lung disease, because normal healthy lungs compared to these black lungs, this is what people get when they work in coal mines for years and decades. Again, normal lung tissue, simple pneumoconiosis, and progressive massive fibrosis. All right, so chest X-ray can be used to determine how advanced the disease is. And you can have small scars or nodules present. The bigger problem is the complicated form. Smoking and a lung condition can contribute to the disease getting worse. And then you can find large masses of dense fibrous tissue in the lungs. And certainly people who have the complicated form will have significantly decreased lung function. And this condition can be fatal, right? But what we find happening is that many workers with poor workers, pneumoconiosis, the complicated form, even when their condition is diagnosed, right? Many of them still opt to continue work, right? And one of the main reasons for this is that to begin with, poor workers, require a lot of qualification to get that job. And if you were to leave that job age 50, 55, it's gonna be very difficult to find a new job. So many of them, they still know they have the condition, but they still up to work. The best that can be done for them in those cases is to put them in areas of lesser exposures within the mine and continue to monitor them. In terms of the skin, big problem. Again, this is a diagram of a cross-section of the skin. The skin has two major layers, the epidermis and the dermis. And below that, you have some other tissue. But the epidermis consists of 4 layers. The outer layer is the stratum corneum. And the stratum corneum is the main protective barrier for the skin against chemicals. So again, the skin is one of the largest organs, comprise 10% of body weight. It carries out several functions, as you may be aware. It's important in asthma regulation. It helps to manufacture vitamin D. It protects us and all of that. However, the skin remains a major target for toxic chemicals as it is exposed constantly to environmental conditions, and especially in the workplace where many chemicals are used. Last time by way of introduction, I told you about the reservoir effect within the skin, where once the lipophilic chemicals go in, they may not extend beyond the stratum corneum. And so the stratum corneum serves as a reservoir or storage, and the chemicals may be released further into the body over a long period of time. So as far as the stratum corneum is concerned, I want you to remember that it is a major barrier against chemical penetration. There are several factors that influence absorption of chemicals through the skin. There are factors relating to the substance, and there are factors relating to the structure of the skin. So hydrophobic versus hydrophilic substances. Hydrophilic substances will pass through much easier than hydrophobic substances. In terms of the molecular weight of the compound, compounds with smaller molecular weights will pass through much easier than those with larger molecular weights. Factors related to the skin structure. The fact is that the stratum corneum is not of uniform thickness throughout the body. There are areas where the skin is much thicker than other areas. And so where the skin is very thin, that will facilitate absorption much more readily than where the skin is thick. So going from a structure that will absorb very readily, so the scrotum will absorb much better than the forehead. The forehead will absorb much more than the scalp, scalp more than the abdomen, abdomen more than the forearm more than the palm, and the palm will absorb more than the foot sole. So the skin structure is important. And also damage to the skin. So if the skin is damaged and you have cracks or cuts on the skin, that will facilitate easier absorption. Or if you have existing skin diseases where you have rashes and those things. And then we have the environmental factors, the exposure time, the concentration of a chemical, temperature, or the solvent used. So the question arises, what is the significance of the skin in toxicology? One, the skin is a portal of entry for several systemic toxins. And two, it is a target organ, right? So the chemicals can have direct effects on the skin or could cause the barrier properties of the skin to be altered so that chemicals could now penetrate more easily. So the skin is very important, and we have to understand this and explain to people in the context of the indiscriminate bleaching that is taking place in the society. People are destroying the skin by bleaching, and that makes it much easier for chemicals to be absorbed through the skin, right? So I can almost see a day coming in this country where we're going to need a lot more dermatologists to deal with all the skin problems that people will have. And it's not if they will have it, I'm certain they're going to have it. All right, in terms of the agents causing occupational skin diseases, they may be mechanical, they may be physical, they may be botanical, chemical, or biological. So there's a wide range of agents that can lead to skin disorders or skin diseases. I just want to mention some of the more important skin conditions in the occupational environment. One of the number one condition is contact dermatitis, in which different chemicals come in contact with the skin. And contact dermatitis is of two kinds. So you can have irritant contact dermatitis or allergic contact dermatitis. And about 90% of all occupational skin disease is due to contact dermatitis, right? And so it is 80% from irritation and 20% from sensitivity or allergic, all right? So that's most common. There are some professions where people are more likely to end up with dermatitis than others. So people who are engaged in a lot of wet work, hairdressers and bartenders, and other people like mechanics who allow themselves to be covered with grease and oil and all those kind of things, right? There's photodermatitis caused mainly through UV light. So people can have um, hyperpigmentation or hypopigmentation. People use a lot of sunscreen agents that can lead to photo allergy. So we need to watch it, right? We need to understand that, listen, people of African origin, we have been blessed with good melanin, which affords us some level of protection. If we're going to bleach out the melanin, we might look a little browner, yes, but we're predisposing ourselves to more and more chemicals being able to enter the body. There's contact urticaria, so you can read up on that. A lot of people, especially in healthcare, end up with being allergic to latex in natural rubber, right? And there are also people who are allergic to condoms made from certain things like rubber as well. So acne is quite common. It's basically an inflammatory papulopustular skin eruption, if you understand what we're talking about. And it is usually an indicator of halogenated carbon exposure, right? We have skin tumors, which may be caused by UV light. we have polyaromatic hydrocarbons, or PAH, like the scrotal cancer I mentioned in chimney sweeps. Arsenic can cause arsenical keratosis or Blackfoot disease. Right? So these are different skin conditions. So that's acne, and that's the arsenicosis, these black spots. So I can imagine that as I speak, this condition could be commonly seen in Bangladesh, where most of the population is exposed to drinking water containing very high levels of arsenic. All right, so these are some of the factors that contribute to cutaneous irritation. The chemical nature, the pH of the chemical, the solubility of the chemical in water and fats, the physical state, whether it's a gas, a volatile liquid, a solid, and of course the concentration, the amount that comes in direct contact with the skin. And these are some of the host factors: surface area affected, region of the skin, length of exposure, dryness. If you allow the skin to become very dry, then in some cases it may crack. And just a cracking of the skin, if exposed to certain chemicals, they could be absorbed in the skin. Presence of hair is like a two-edged sword. So in some cases, because there's hair on the skin, it helps to retain more of the chemical on the skin, more harder to wash it off, right? And then if there's no hair on the skin and the chemical comes in direct contact with the skin, there can be more problem. Of course, if you have pre-existing skin disease, then it's gonna be easier for chemicals to enter. And then those are some of the general and environmental factors. In diagnosing skin condition, a history is very important. Job history, current job history, prior employment, your off-work activity, your medical history, your family history, and followed by a physical examination. And in some cases, you may do patch tests if you want to find out if people are allergic to certain chemicals. This is an illustration of the patch test. The medics in the group will know much more about this. What time is it? May I ask? I can't see the time.
3:37, sir.
What time is it?
3:37.
3:37. All right, so I'm
Mhm.
going to start the next lecture, but I'm certain I won't be able to finish it, but I will send it to you nonetheless, so you have the information. But let me see what portion of it can be covered. All right, so there are other important organ systems which can be impacted by the occupational exposures. So if we look at the musculoskeletal system, there are a number of musculoskeletal disorders that may involve the back, the cervical spine, or the upper extremities or the hands. Now, low back pain is one of the oldest and probably most common musculoskeletal disorder, and it's very costly. There are many causes. It tends to be chronic, right? And in a lot of the cases, the cause may be non-specific, or it's very difficult to determine what is the causes. We should note, however, that some of the changes may be due, change in the spine, for example, may occur as we get older. right? So never rule out age. One source tells us that these are the top 5 causes of back strain or sprain, lifting improperly, making a sudden movement, falling down, carrying excess body weight or a heavy handbag. I don't know what you have to say about the thousands of children who go to school with what I call a burden on their backs. I don't know if they need to take all their books to school every day. When I went to high school, we got a timetable which indicated which subject we have which day. But if you look at the size bags that some of these young ones are carrying, you may get the impression that they probably carry all the books they use in school on a daily basis. And this is going to certainly affect their posture and long-term, could have long-term consequences. So poor posture is a common cause of back pain or strain or sprain, whatever you want to call it. There are some very high-risk jobs for musculoskeletal disorders, construction industry, for example, where there's still a lot of manual lifting and pulling and pushing and stretching taking place in mining, in transportation, in manufacturing, right? I I recall back in the day when we had few minibuses on the road, and I lived in Portmore, and there were not many buses, so the buses were really overloaded, and that in itself could cause some serious back problems as a commuter. And one morning I decided that I wasn't going moving 1 more inch in the bus, right? Because it was near impossible. And the conductor looked at me and said, "Man, like if you buy a car," right? So I was not happy that I couldn't step off the bus and go and buy a car, but I did eventually because traveling by bus is like it's a jungle out there. In terms of prevention, a number of options are available to prevent some of this problem. Job design, the whole area of ergonomics, job placement, you select the right person for the right job. You design the workstation to fit the worker, right? What I see happening now, especially in the what do you call that industry? The what they call it, telecommunication or the BPO sector, where you have workers in some serious position they can hardly turn or twist, and they have to remain in that kind of posture for hours, right? Training and education, very important. And the training should not only be confined to workers, it should also include managers, labor union representatives, medical practitioners, and others. Some of the disorders of the upper limb and the neck, with the wrists, you can have what we call carpal tunnel syndrome. There's a carpal tunnel in the wrist, right? Remember that. And the median nerve passes below the carpal tunnel. And so if the carpal tunnel is now compressed against the median nerve, that is going to cause pain, tingling, numbness, all of those things. And people might end up with the problem of dropping things because the hand can't hold things properly anymore. All right? It's a bigger problem in females than males because the carpal tunnel of the female is much smaller than the carpal tunnel of of the male. So it is easier for the median nerve to be affected in the wrist of females than in men. All right. There's what we call trigger finger, where the finger locks in either an extension or flexion position, and it requires assistance in unlocking. There is tendinitis, localized pain and swelling over muscle tendon structure. And right, so we're just illustrating this is carpal tunnel syndrome, right? So within the wrist here, you have the carpal tunnel, and then the median nerve is compressed at the wrist. And this is what results in all of this pain and suffering. For trigger finger, you can see the shape that the finger assumes, and in some persons, they can't straighten the finger after a while. So that's why they call it trigger finger. The tendon sheath there is affected and all of that. For tenosynovitis, right, you still have inflammation there. You have lateral epicondylitis or tennis elbow. And what happens here is the flexion, the extensor muscle is affected. So you have inflammation here, which makes it very difficult to bend or straighten the arm. And so people like tennis players and other people get this condition. All right, so you have the lateral epicondyle, you have the inflamed tendon, and so the extensor muscle, when you try to extend the arm, then there is severe pain. For the neck, you have something known as tension neck syndrome, and up with neck pain or stiffness. We spoke a lot about cancer. Just to mention a few things, so I'm skipping a few slides. All right, so whether you're a midwife or a nurse or a doctor, once you're in occupational safety and health, you need to familiarize yourself with this diagram, because what it is showing, it's illustrating the developmental progression and susceptibility to teratogens and fetal loss. And you will know that different organ systems develop at different times. And so depending on when the mother, for example, may be exposed, you may have different teratogenic effects and all of that. So these are some of the problems that can result from maternal exposure to chemicals at work, reproductive wastage. You can have genetic defects, congenital malformation, low birth rate baby, mortality, developmental disabilities, behavioral disorders, and worst case scenario, malignancies. All right, so briefly talking about teratogens, timing is very important. And so the effect varies with the developmental stage at the time of exposure. And you have the pre-differentiation, differentiation, fetal development period lasting for a number of weeks. And just to look at one teratogen, you must have heard of thalidomide. If the mother is exposed, days 34 to 38, the child could be born with ear abnormality. 40 to 44 days, arm abnormality. 44 to 48, leg abnormality. So it's the same chemical, but depending on when exposure takes place, the teratogenic effect will vary. So this is just some information about thalidomide. It was used to treat nausea and vomiting in pregnancy. And then they had this epidemic of birth defects. 185 infants with absence of shortening of extremities, which they call amelia or phocomelia. And the association was made to the mothers being exposed to thalidomide, right? And then we had diethyl sylvestrol. I think I told you about that, didn't I? You spoke about diethyl sylvestrol? Hello?
And I don't remember if we spoke about it, sir, but it sounds familiar indeed.
The thing is that I talk to so many groups about these things and I forget who I spoke.
It sounds familiar.
But briefly though, there was a period in the past when women got pregnant and they were threatened with abortion. And so they developed this synthetic hormone called diethylstilbestrol, or DES for short. And they gave it to the women who were pregnant, and it saved the pregnancies, right? So everybody was happy. Until down the road, a number of young ladies were now being diagnosed with a rare disease, adenocarcinoma of the vagina, which is a rare cancer, which usually affected older women, but young ladies, late teens, early 20s, were having this condition. And everybody was worried, but it didn't take them long to solve the mystery, because these young ladies who were presenting with adenocarcinoma of the vagina were the offsprings of the women who were treated in pregnancy with diethyl sylvestrol. So this is a classic example of what we call transplacental carcinogenicity, right? There is mention also in the literature of fetal alcohol syndrome, and it's one of the leading causes of disabilities and all of that. There are a lot of facial abnormalities, and we have information for the US. So how much, okay, it's 351, okay, all right. So for FAS, the face, you have a lot of facial signs. So you may have microcephaly, which is a small head, right? You may have what I call a flat mid-face, right? A small chin, thin upper lip, a short nose, and a low nasal bridge. So if you look at this face of this child, it looks a bit twisted, right? So that is called due to mothers drinking a lot of alcohol during pregnancy, so called fetal alcohol syndrome. And there is also what they call, all right, direct your attention to this information, right? So FAS was described in the late 60s, early 70s. 1981, the US Surgeon General advised women should not drink during pregnancy. By 1989, there was a warning label on alcohol sold in the US. 1990, the US government clearly stated that women who are pregnant or plan to get pregnant should not drink. By 1998, more than 50% of pregnant women drank. So I don't know. I don't think we have corresponding data for Jamaica, but I know, for example, that in our maternal and child health services, women are advised not to drink when they're pregnant, or not to smoke. But I wouldn't be surprised if we still have some pregnant women in Jamaica who drink and smoke. I don't know, what is your experience? Any comment on that? What the
We
doctors
do have
do?
some pregnant women who drink and smoke, and we try to get counseling for them. So if they come early for
Mhm.
antenatal care, We
Mhm.
refer them to the social worker and psychologist to help them. But the problem is a lot of them who drink and smoke throughout the pregnancy, they don't want to get antenatal care either. So they just show up most likely
Okay.
in preterm labor.
Oh, yeah. Yeah. Alcoholism is a big issue. I mean, alcohol is socially acceptable, right? We we drink it and we advertise it and we try to remove the blame from ourselves by telling people to drink responsible. I don't know what that means, right? I don't know what nobody never explained that to me. But all right, you have this other thing they call fetal alcohol effect. Um, some people thought it was a precursor for fetal alcohol syndrome, but we are now learning that it's two distinct conditions. But the good news is that both of them are preventable, right? Again, these are exposures associated with multiple adverse reproductive endpoints. Alcohol can cause spontaneous abortion, congenital malformation, low birth weight, developmental disabilities, anesthetic gases, spontaneous abortion, and congenital malformation, lead, and organic solvents. So it is well established that certain chemicals can lead to adverse reproductive outcomes. All right, I don't think I'm going to start ionizing radiation. We still have a few more slides to cover. So I'm going to leave it here, but you should get the lecture so you can read it through. But there are one or two things I want to discuss with you, things like hearing loss and problems to the eye and a few others. But we will take it up next time. So you can ask Miss Prince for the hard copies of the lectures, and I will post the lectures to the course site. All right? Any questions? Are there any questions or comments? Did I go too fast? Speed at which I go is directly proportional to the amount of stuff I need to cover in a short time. So if after you get the lectures and you have any questions, you can contact me, preferably through email if you need any further explanation on anything. All right? So
Okay, sir.
have a good afternoon.
Good afternoon, sir.
Okay.
Thank you, sir.
All
Thank
right.
you.
At the start of the class, one other thing. Hello?
Yes, I'm hearing you still.
At the start of the class, I was having internet issues again because I had started talking up, but you couldn't hear me. So I was asking, we got the new date for the trip?
You're asking me or you're telling me?
I'm asking if we got the new date for the trip.
And that's to the biscuit company?
Yes, sir.
Right. We have asked Miss Prince to make the contact and follow up since she is ideally placed to do that. We haven't had any word from her yet, but as soon as we get it, you will get at least a week's notice. So I'm going to ask her for an update. Okay?
Thank you, sir.
All right. Have a good evening.
You too. Have a good evening.
Yeah, thanks and bye.